A very warm and happy good evening to all of us and to all of the doctors who have joined. Today we have with us Dr. Adrija Rahman Mukherjee. She is a general practitioner trained in the UK with over 30 years of experience. She's also an MRC GP trainer and examiner and my mentor. Welcome, Adrija.
Thank you.
So today's seminar is going to be on common rash presentations in primary practice. And this is one issue that baffles me to the core. Every single time I see a rash, I keep second guessing myself, although I think most of the time as GPs, we do have an inkling with the history and the presentation by itself. But Adrija, I'm all curious and excited to know what we have in store. So over to you.
Thank you, Archana. Today we will talk about rash. So why rash? Because this is something with which the patient usually presents very early, because as it is on the skin, it is quite evident, and nobody likes to look ugly, or if it is a itchy rash, or if there is something, a redness or a lump or bump, definitely they get very anxious. So sometimes they just do come to know that what is the reason for this rash, and sometimes they want to get a remedy or relief from the symptoms what they are getting. So there are many things which can give a skin rash. So that's why I have to divide my session into part 1, part 2, perhaps part 3. So let's start with part 1 today. So let me share my screen to you. Okay, so as this is a case-based discussion, let me ask you the questions. I know sometimes it is difficult for you to answer straight away, but you know there is a chat box where you can answer, and it would be lovely to know some answers from your side. Then we can interact a bit more, because sometimes, just seeing the rash, you might know, oh, it is so simple, why she is talking about it. But the reason I'm talking about it today, that I have seen in a lot of cases, the management is not up to the mark. For that reason, patient suffers a lot. And there is a notion that if there is a skin rash, give some steroid, give some antibiotic cream, and give some antifungal. This cocktail will work for it. But sometimes it might not, or it might make the case worse. So unless you know the diagnosis, how will you treat it? Then you will say, okay, I can send this patient to the dermatologist. But interestingly, I have seen that there are many cases where dermatologists are doing their bit, but there are more to it. So maybe some systemic reason is giving rise this rash. So that is why let's start with that. It's a simple case to start with. An 18-year-old student attends with an itchy rash in her hand, forearm, upper back, and axilla after a college trip, which has happened perhaps a month ago. The itching is affecting her sleep at night. So this is the presenting thing, and you can see the rash. I hope there is no problem with seeing the slide and making some diagnosis out of it. So my question from this first case is, what is the diagnosis? What are the signs on physical examination? And how will you manage the case? So I will give you 30 seconds to give some answer to these questions. Somebody can write about the diagnosis, somebody can write about the signs in non-physical examination, and somebody can write about some management. So whoever just put some answer to it.
Adrija, do you think we can see the slide with the picture again? Thank you.
Can you see the chat box? Because I can't see the chat box myself here from your side. If you
yes,
see
Adrija, I'm able to view the chat box. I'm waiting for answers for the diagnosis, signs as well,
And the management.
and the
If
management.
anything comes up, just let me know.
Sure.
Yeah, somebody has put something there. Can you read it out for me?
So, Audrija, that was one of the reasons I used the chat box was to know if somebody had missed the questions. So I just wanted them to look at it. So what you're looking at is asking for diagnosis. What are the signs and how do you manage it?
Okay. So
So,
you go ahead.
Audrija, I'm thinking if a student goes for a college trip, it could be that the student would stay in a dorm or a hotel. But I'm thinking maybe when students as a undergrad student, I lived in a hostel, and these kind of rashes were pretty common, I must say, especially in the boys' hostel. And should I take a go at it?
Yeah, please
So
carry on.
I am suspecting it to be scabies because you also mentioned these were itchy rashes. And
Mhm.
one of the signs is possibly that there is a lot of itching in the web spaces in the palm.
Right.
Uh,
Yeah, actually, what happened that when this infection happens, the this is caused by a very small, tiny mite called Sarcoptes cabii, which just make a burrow. Particularly, they love to do it in the web space, and they stay there. And at night, they usually crawl somewhere and produce a toxin, and which gives an intensive itch, particularly at night. But honestly speaking, when the case gets a bit advanced, if you ask the patient, they will say they itch throughout the day. It is not that particularly at night. So, but maybe for other patients who say it is mostly at night, could be one reason that toxin mostly released at night. Secondly, that they are quiet, they're undistracted. So it is so troublesome that that can affect their sleep. So that is why in that state, they come. Now, interestingly, I have seen that when I make some slides on some cases, I used to see a lot of cases. Maybe it is a something what we call focus. In last 2 weeks, I have seen at least 3 to 4 scabies cases, and all of them been in with the dermatologist, and two of them rather treating them for allergy, and some of them been the other two also, they self-medicate themselves because they come and say that, doctor, I have got an allergic rash. One patient, I was they come with some toenail problem, and then when I was examining her, I just saw that some spots like this, which I have shown in the picture, are there. So then I realized that it is just not the some toe infection or allergy. There is more to it. So I asked her, is there anywhere else you have the problem? And then she showed me the hands. Mainly, it is there in the hand, in the back, in the belly button, and in the groin, everywhere. So there, when it starts, it usually starts maybe in the hand, because maybe sometimes from hand shaking we get it, but it can spread anywhere in the body. And also, you have to ask these people that, do you have anybody in the family who is also scratching and itching? Say, some of them might say no, some of them I'd say I might not know, perhaps they have got the problem, and some of them will say yes, my sister or my younger daughter or somebody is itching as well. So you have to treat the whole household. Otherwise, what will happen if you treat only the patient, they will again catch the infection from the other persons, because it is very much infectious and contagious. So that is why, in fact, I personally contacted KBSY just because when the patient entered, I had a habit of shaking hands with the patient. It is a pre-COVID time that time. And I, after some discussion with the chest problem, and she just mentioned, doctor, I want to show you some rashes. And then when she showed me, I realized, okay, gone, I'm gone. And it happened. So that is why I'm saying that nowadays it's good after COVID, we do just like this, or hello, we don't really shake hands, or physical contact is minimal. So at least we don't contact the infection that way. So burrow, especially in between finger wave spaces, this is a favorite place. So you have to carefully look into it. So when you are looking into it, just ask the patient to stretch their fingers and you just look into that area. Linear marking in the skin, I will show you the picture, some red papules or even pustules, some pus might come up. And in that case, you have to treat that secondary infection. Pus is not happening because of the scabies. It is because of the scratching, there is breach of skin and the secondary infection. So if you just treat them with some lotion or ointment, that might not cure the secondary infection. So we have to take care of that secondary infection as well. And those fold areas, that finger waves, axilla, chest means below the breast, umbilicus, genital area, you have to be very careful, and you have to warn the patient that when you are applying the lotion, you have to take special care of this area. Now, I have seen that when we do the exam, when the treatment of scabies come, we say 5% permethrin. But when in India we treat scabies, we usually use a lotion called Scabex or Scabipet lotion, which contains cetrimide and benzyl benzoate. These components helps to get rid of the scabies very easily. It's not a very difficult cases unless it is a complicated one. I will come to that later. Should take a shower, but not a hot shower. Why? Because if it is a hot shower, then there is a chance of absorption of this lotion. So it has to be just normal water shower. If they don't want to take a shower, it's okay. They have to apply it from neck to foot, taking special care of these folds, and tell them not to wash your hand after application, because otherwise they will miss this finger waves. And they have to say go to bed. After applying that, it will get absorbed and it is that colorless and whatever, so there won't be any problem. Next day they have to wash their clothes and linen properly in warm water, and they have to take a shower. If the scabies is that bad, which I have shown in the picture, it is better that they apply it again after 7 days. But it is just might take a bit of time to get better, particularly with the itching. Even if the actual scabies is gone, the itching might persist. So they can use some kind of anti-itching thing like Atarax, or Atarax is very sedative, but it helps them because it helps in itching and as well as helps in this sedation. So because they can't sleep properly. Or you can simply use fexofenadine before going to bed or before dinner. So that help them with some itching. But continue with that for 10 days even after application, so that it completely helps the symptom. So patient becomes very grateful if you can treat them properly, because really this is a bothering problem for them. So this is what I call that erythematous inflamed papules and pustules. You can see this linear marking. So these are some signs which I want to highlight. And this is a very bad type of scabies. Usually we don't see this in a very urban, poshy population, but even in urban areas, in some population. Now, sometimes what happens, we confuse this with either contact dermatitis or psoriasis. So you have to be very careful. If you see there in this kind of cases, say psoriasis, the margin is more specific and there is a bit of flake there. Though it looks like flaky, it is not a flaky actually. And contact dermatitis won't happen in other part of the body. Mainly this restricted in the hands or the feet where the contact happens. Or this kind of rash, it's usually sometimes with the earrings or with the necklace it happens, but it is actually associated with some kind of contact history. So if you see this kind of rashes, it can be cases of crusted cavies or Norwegian scabies. In this kind of patients, a simple application of this permethrin or benzyl benzoate might not help. So you have to go for oral medication. Now, oral medication, or if the scabies is coming back again and again, in conjunction with topical treatment, you have to use ivermectin. So in the case of recurrent scabies, you can give a dose of ivermectin. It depends on body weight. Either you can give 12 milligram, or if the body weight is low, 6 milligram. First dose in second one, and second dose is on the second week actually, between 8 days to 15 days, another dose. So that is the treatment of just the scabies is not stubborn and not going with the lotion which you are giving. But sometimes the scabies is quite bad, which you have seen in the picture. There we might need to go for a longer duration of ivermectin treatment. So one thing you have to remember, it is not the ivermectin, if I am giving longer duration dose, it does not mean you have to give 5 tablets in 5 days. So 1, 2, then you have give a gap of 1 week, and 8, 9, and then a week gap, and then the 5th dose. So in severe cases, you have to go like that. Mild cases we have mentioned, and moderate cases in between first and second day, you give first or second dose, and then the next week you give another dose. So that's how. So there are a lot of things in the scabies also, though it, as Archana, you mentioned, that is a very simple thing. In the dorms or in picnic or somewhere, you go for an outing for a day, and when we don't have money, we share our clothes, we share our bed sheets, and we are not going to a poshy hotel, and there are very many chance of getting this kind of infection. So I'm coming to the next case now after this scabies. A 38-year-old lady presents with this itchy rash. She tried different home remedies and self-medication over last 1 month, but it is gradually getting worse. So again, the question will be almost the same. What is the diagnosis and how will you manage the case?
Doctors, you may use the chat box to send in your answers.
Oh, sorry. Anybody is coming with any answer? It would be good if it is a bit of, I know it takes a bit of time to write and when it comes.
So, Audrija, we have an answer. Dr. Vijaya says Tinea corporis.
Yes, yes. And if Vijaya or somebody else, Dr. Vijaya, thank you for participating. And if somebody else can say that how will you manage, or if you can just enlighten us that how will you manage this particularly case of Tinea corporis? Maybe you can write 1 or 2 medicine that will help us.
So, Audrija, how would you describe this rash? To me, it looks annular crusting with slight central clearing. Is that the right way to describe it?
Yes, you can, but say if somebody says no, I don't think it is ringworm, it is something else or not a Tinea corporis, you can always say that. So because unless we come up with some DDs, differential diagnosis, it would be because I know this is ringworm. You might not know this is ringworm. So in that situation, I'm talking to the whoever is hearing this, that if you think that it could be something else, it might not be a ringworm, it might be whatever is coming to your mind, you can put that as a diagnosis. Then we can always make a DD out of it, that why it is, or you can ask that why it is not this. So why it is not psoriasis, why it is just a ringworm I'm thinking of. So, as Archana, you have mentioned that there is a bit of central clearing, and then there is a margin where you can see some small papular rashes, and it is very itchy. So, this total picture, if it is, say, what else it could be? It could be, say, as I have said, that whether it could be psoriasis, but psoriasis usually have a scaly rash, there won't be any central clearing, and it is more flaky rash we see. It is not like this kind of rash we can see here. So when it comes to the diagnosis, yes, we think it is ringworm, but sometimes we, in this particular cases I have seen, we use a lot of steroids, which is not really needed, because there is no secondary infection, there is no other side of kind of inflammation. But sometimes it needs a longer duration of treatment. Sometimes just the topical treatment might not help. And nowadays, because of this advertisements, people, they use some kind of creams before they come to you, and then you have to take it further. So the question I made, that this tried some home remedies, they sometimes put some coconut oil, or they tried some over the counter, say this creams, but that might not get better even after using. So they might use the candid cream, but it is still getting worse. So in that situation, we have to take over. So yeah, topical, you can use this. Our favorite, we use clotrimazole cream, but this kind of rashes, which is this big, it might not get better with topical treatment. So here we have to give some terbinafine or itraconazole after checking the liver function and after checking the heart. So itraconazole sometimes in heart patients you have to avoid. And this both the drugs, all these drugs, they passes through the liver. So you have to be a bit careful with the liver function when you are using this medicine, because sometimes you have to use this medicine a bit long term. Now, with the corporis, you can use a month treatment of itraconazole or terbinafine. Usually, we use terbinafine 250 milligram, itraconazole 100 milligram. And nowadays, there is a popular thing called pulse doses of itraconazole, where they are using 200 milligram of itraconazole twice daily for just 7 days. So they are saying this is working better. But definitely, if you are giving a pulse dose, you have to make sure you know about the liver fund condition and heart condition of the patient and then give it. Another thing, timing of the drug is very important, particularly with this antifungals. When you are giving this drug, do you want to give it in empty stomach? Do you want to give it with food? And what kind of food? These are important. Usually, itraconazole should be given with a meal, preferably some milk or fatty milk, they say. And some sites I've seen, they are saying with acidic thing like cola or something. But normally we say take with your breakfast or something, but they should not have an antacid 2 hours before or after taking itraconazole. So, in our country, a lot of people are on PPI, self-medicating themselves for ages. And if you tell them to stop this PPI and take this medicine, they would rather prefer to eat and scratch rather than stopping this PPIs. So in that situation, you have to give them in a different time, like lunchtime or dinner time, where they are not taking any antacid along with it. Usually, it does not need any antacid as such, because they think anything like this is an antibiotic. You have to tell them antifungal, and you don't need to take an antibiotic along with it. So you can safely take this medicine. But the ringworm, as you said, Dr. Vijay, that it is a Tinea corporis, that means in the body. But it can happen anywhere. It can happen in the scalp, it can happen in the nail, it can happen in the hand, it can happen in the groin, it can happen in the feet. And accordingly, we name them differently, and also the treatment differs. That is very important. So next case I'm showing, I think if the diagnosis is quite obvious now after the previous slide. Anybody like to share that? What do you think?
Audrey, I also see some flakes here.
Yes, I can understand what you are saying. Yes, what you are thinking, that if there is a lot of flakes, do you think it could be something different?
I'm actually thinking if it is
Whether it is
coexistence of
rashes or
two
not?
things, maybe seborrheic dermatitis along
Hmm.
with tinea,
Mm-hmm.
because I do see a rash in the area where the quantity of hair is less.
Right. Now in seborrheic dermatitis, if you see, there is not much alopecia. If you see here, the alopecia is quite significant. And can you see this patch on the top? Can you see the cursor which I am just putting on, or this area in the middle, or this area? So this is not normally seen in seborrheic dermatitis. Number one. Flakes is just as the scalp is dry and there is mucky secretion is also there. You can get this secretions of the scalp there. It is may not be just flakes. So that's why you have to examine the whole hair properly. And also very important is the history, that when it has started. Usually it starts small, then it gradually spreads, and it spreads like this. And why it is not alopecia areata? Alopecia areata, this skin is very clean type of thing. And if you see there is a hair there, it is a question mark like hair there. But here you are not seeing that, it is almost hairless area. But you know, this area, as though it is hairless, you can get a feeling that if you treat the area, the hair will come off. It is not that clean bald type of baldness, the hairless type of baldness, where you won't get any hair follicles there. If you see properly, there are hair follicles. So these are the differentiating point. That is why it is important, because in one case we are treating this with steroid, in one case we are treating with antifungal. Now in Tinea capitis, here, though we use a lot of local application, but what the research is showing, that their use is really limited. I mean, their efficacy is really limited. We use this ketoconazole shampoo, selenium sulfite shampoo. These are the normal antifungal we use on the scalp. We will use them definitely. Maybe twice or thrice a week we will use them. But with this kind of Tinea capitis, just by local application, it won't get better. So in that case, we have to use some oral medication. And when you are using oral medication, it has to be a bit longer duration medication. So anybody has got any idea that how long it should be used? It will be very short answer, so you can just type it. Anyone?
Dr. Audrija, we have an answer. They say 4 weeks.
4 weeks, yes. With which one? Which drug, you know?
I think they've typed KCZ, so I'm assuming it is ketoconazole.
Ketoconazole, yeah. So ketoconazole 1 month. or 1 week. What you said?
4 weeks.
4 weeks. So ketoconazole. Interestingly, ketoconazole has not that much of penetration in the scalp, right? So in that situation, the ideal oral medication is again itraconazole or terminafine. Minimum we have to use it at 4 to 6 weeks. So it depends on the situation. What we have seen that in case of itraconazole, 1 month treatment may be good enough. But with terbinafine and fluconazole, grisofulvin we not use so much nowadays. With terbinafine and fluconazole, it has to be 2 months. So it all depends on the case. And if you see, you can use up to 3 months. Now, if you are using itraconazole for longer duration, say 100 milligram, it won't be good enough for scalp. You have to give 200 milligram in a single dose in a day, and you have to continue for 1 month or 2 months. But sometimes there is, as I have mentioned you, the pulse treatment. If you have to continue with the pulse treatment, you have to give, say, 1 week, 200 BD of itraconazole, give a 3 weeks gap, and again 1 week, same dosage, 200 milligram BD, 1 week, and then 3 weeks gap. That's how you can give a pulse treatment up to 3 cycles, 3 months. So for the scalp, better you either use pulse treatment or you can give 100 milligram, but definitely not less than 1 month. So you have to tell the patient, even if your symptoms are getting better, you should not stop using the medicine or taking the medicine till I say to stop it. Ideally, you should take a scrape from the wound and send it for culture. Until it is culture negative, you have to keep on treating it. Problem is, in our labs, it is not always very easy to get the fungal culture. So nail clipping, sometimes we send it, it takes 7 to 10 days. So will you wait till then? Or will you ask the patient to continue with the medicine? So it depends on the case. If you are confident and experienced enough to how to treat it, because sometimes we send the patient to the dermatologist. You need to know your limitation though. But if you are confident in treating these cases, why don't you give it a try? At least the patient won't die of after using this if you are taking care of liver and other things. So in a healthy patient, they can also develop this. Now, particularly with this Tinea capitis, patients are very much worried about the hair loss. But you can assure them that after the treatment, as the hair follicles are still alive, you have to examine that properly. They will get a proper hair growth after the treatment in months or year. So you can reassure them, which this reassurance you might not give in many other patients with other scalp condition. So what I am saying, that though you are using some shampoo or selenium sulfide or ketoconazole, the mainstay of treatment is oral medication, and that should be at least for 4 to 6 weeks. Sometimes it can go up to 2 months. Now there is a point there, a 64-year-old man with diabetes. Here I have specified a condition, presents with this nail changes, right? So that's what I have said, that this condition may come to you, may come to diabetologist, may go to a dermatologist. But if it comes to you, how will you manage? So diagnosis, we know it is onychomycosis. There is bad fungal nail infection. But how will you manage the case? So definitely you have to give a prolonged treatment of itraconazole or terbinafine. Here the treatment is not less than 3 months. You have to give the treatment for 3 months. Why? Now, if you see the rashes, now from the nail bed, usually the healthy nail, it develops. So it takes approximately 1 month to make the nail bed healthy, because this is at the moment it's a dead cell. So unless you can get a complete healthy nail, then from this area again the infection can spread. So that is why the healthy nail will start growing from this nail bed, and gradually you will see an area of healthy nail, and you can just ask them to clip the affected area straight away, not with this curved thing, just straight way. They have to cut their nails. And also, why we are bothered about this kind of condition, because this patient is diabetic, so and patient, you have to give the medicine for very long duration. Diabetic patient has got a lot of metabolic syndrome, including fatty liver, kidney problem, all these things. So you have to take care of that. At the same time, as you know, that any fungal infection can flourish in diabetic patients. So you will have trouble in controlling. So unless the diabetes is controlled, you will have problem in controlling this nail infection also. That is why together you have to manage the diabetic control as well as the fungal nail infection. More important is that whenever there is a breach in the skin, the infection can get inside, and you know that diabetic foot ulcer and cases of amputation, how high they are in India. So it can start with such a simple thing, just a fungal nail infection, which is pretty common. And then it can progress to that. So it is not only about diabetic patients, for normal patients also, that we are in the office for a very long time. Let it be female or male, we are wearing boots and closed shoes and socks. Sometimes some people, they're not washing their socks for many days. I always get the complaint from the either girlfriend or the boyfriend or the mother that my son or my daughter, they're not washing their socks, or they're not allowing me to wash even. So this can happen to them, though this is not a young patient's feet, but I have seen this problem in the younger generation as well. So ask them to, you have to keep your feet open and in the air so that it can dry up. They have to every day clean their feet properly, take particular care of the web of the toe web, and they have to trim their nail properly. When the infection gets over, they have to make sure they don't get the infection. And sometimes some shoes, the leather shoes, if you can ask them, put some candid powder inside when they're wearing the shoes, or at night when they're keeping the shoes. And sometimes they ask them to put the shoes in the sunshine so that it can just get dried up. So these are the precautions you have to ask them. It is simple case of fungal nail infection, but there are a lot of things you can do so that patient don't catch the infection again, or they can completely get healed out of it. So I have discussed this thing. Now we are going to case 5. Right. A 48-year-old man presents with an odd taste in mouth after his discharge from the hospital following a prolonged treatment of pneumonia. His mouth examination is shown below. So now tell me that what are you thinking about this?
Doctors, please share your answers either on the Q&A or the chat.
Somebody has shared
Thrush. Yes, Audrija, somebody says oral thrush.
Right. So my question is that how will you manage this case?
Any answers, doctors? How would you manage this?
Can you just name one drug? That would be good.
The usual go-to that I have given is fluconazole, but somebody here also mentions candid mouth paint.
Right. Okay, both are right. So you can use both together, but because this is, as you can see, this is quite extensive thrush. The problem with the oral pain that they don't stay in the mouth for very long. As soon as you applying it, you are swallowing it, and so it does not stay. That is why you can use this candid oral paint or Distatin oral paint, but along with it, you have to take some oral medication. Usual doses for this kind of patients, say they just come out of the hospital, had a lot of antibiotics, and develop this, an elderly patients, you can simply give fluconazole 50 milligram for 2 weeks or itraconazole 100 milligram for 2 weeks. But in some immunocompromised patients, because sometimes this oral and esophageal candidiasis can be a sign of HIV. So in immunocompromised patient, you have to go for longer duration treatment for 2 to 3 months, because sometimes this patient even complain of problem with swallowing. And sometimes when patient complains of swallowing, we straight away thinks that is the problem with the gullet. It is not. It might be the problem in the throat and the tongue, just with the fungus. And if you treat the fungus, the patient will feel better. Now, as we are discussing a lot of fungal infection, it's very common that this kind of white tongue just come as oral candidiasis. But why not leukoplakia? Why not it is lichen planus? Why not it is some cases of what else could be? Some enteric fever like typhoid also can give white coated tongue. So you have to be very clear. It's a very curdy, thick kind of coating we see in candidiasis. Whereas in other conditions, there are other features like in leukoplakia, this thickness is not there, or it's very localized. In lichen planus, with that, you can get the lacy pattern of this rash. So whenever you are seeing something, you have to keep your mind alert that, am I missing something? So that is very important. Now, with the management, as I have said, that nystatin oral paint or clotrimazole oral paint, or what we call candid oral paint, you can apply. Orally, you can give this fluconazole 50 once a daily for 2 to 3 weeks, and higher dose for immunocompromised patients. Now we come to the case 6. A 34-year-old woman presents with vaginal itching, curdy vaginal discharge. She's diabetic, she's on metformin, but her HbA1c is 7.8 and BMI is 27. How will you manage? Now, as we are running short of time, now I have to expedite. What I want to highlight here, definitely we know that it is a vaginal thrush, and you can give either fluconazole 150 milligrams stat dose, or you can give some vaginal clotrimazole pessary for 3 days. But that is not enough for this particular case. The patient is diabetic and diabetes is not under control, and the BMI is high. As normally we separate these two things as a doctors most of the time. And what we do when we see BMI is high and HbA1c high, nowadays we have got a tendency to add SGLT2 inhibitor in this kind of patient. So DAPA, IMPA, CANA, whatever gliflozins we add. Yes, that will definitely bring the HbA1c very easily, but that can aggravate this problem. So when you are treating a diabetic patient, may not the diabetic patient will tell you about this. You have to proactively ask the patient, is there any vaginal itching? Is there any recent history of UTI? And then you have to give the drug or add a drug, like based on their financial condition, you can use a gliptin or you use sulfonylurea. It's your choice. So, but that won't be, you will say that what will happen to BMI? Yes, definitely that won't help the BMI. Gliptin, at least people say it is wet neutral. But this glimepiride or diglycoside, they can even increase the weight a little bit. So you have to think about it, but don't use any SGLT2 inhibitors. And whenever you are including or this medicine in the patient's particularly in female. I'm not saying only about the female. Male patients also have this penile itching and penile discharge. And they go to the doctor, they just give this cream, antifungal cream. They are getting better temporarily, and again it comes back. So unless you stop the drug, patient won't get cured. So I've mentioned that. Case 7, again another diabetic patient, they are getting recurrent vaginal candidiasis and on metformin and empagliflozin. So in this situation, again, you have to separate. If it is a recurrent vaginal candidiasis, you have to give a long-term treatment. But first, you have to stop the empagliflozin. But if you are stopping, definitely, if you have to add something. So use a gliptin or something to compensate this empagliflozin. And for that recurrent vaginal candidiasis, what you can do, you can use 3 doses of fluconazole 150 milligram, 72 hours apart. Now, I was just in the last month for an exam, conducting an exam as an examiner. So a lot of people, they don't have, or doctors, they don't have any idea about how to treat a recurrent vaginal candidiasis. And I'm telling you, and particularly with the male doctors, I'm warning, you have to understand this is a very troublesome condition for the females, and it is very easy to treat. So if you have to keep an eye on these things, that whether the diabetes is under control, if SGLT2 is not there, and if their hygiene is good. Hygiene means that they have to wear cotton loose undergarments and keep the area dry, that kind of thing. And along with that, if you use this medicine, fluconazole 150, I've taken every 72 hours, 3 doses, that might be good enough. If it is really bad recurrent, so maybe you have used that and didn't help, then you have to use fluconazole after treating this 72 hours gap, 3 doses, 150 milligram once weekly for 6 months. So that is the treatment of resistant or recurrent vaginal candidiasis. This is one of the commonest cause of vaginal itching. Maybe there is a superadded infection like bacterial vaginosis, other things, but this is the commonest. So if you ask them about the discharge, if they say that it's staining the undergarment, it's a thick discharge, just go for this fluconazole 150, 3 doses, 72 hours apart at bedtime. That will help them.
Audrija, we have a question here. Is that
Yeah.
okay?
Yeah,
So
sure.
the question is, do we need to monitor the LFT when we are giving 150 milligrams once a week for 6 months?
I think there is no harm after 3 months when you are bringing the patient for diabetic check, just to include at least a SGOT, SGPT, and gamma GT there. Now, interestingly here, rather than SGPT, gamma GT and SGOT will rise. Because a lot of diabetic patients, there will be liver function derangement. So in that situation, if you know the baseline LFT, then it is good. If you don't know the baseline LFT, you just get the first LFT in 3 months and you see SGPT is 88 and SGOT is 55, you will be confused that whether it is due to fatty liver or whether it is due to medicine. But just to know the fact that drug-induced hepatitis usually cause more rise in SGOT than SGPT and also rise in gamma GT.
Thanks, Audrija.
Thank you. Now, this is another case. Now we are coming out of this candidiasis thing. Can you see that? There is a 40-year-old housemaid presents with this skin rash. She has no rash elsewhere. I think everyone has picked up this. So, and we are seeing this kind of cases a lot. It's not only housemaid, the other homemakers or anybody working with some detergent or some chemicals, they can develop this kind of rash. This is contact dermatitis. Now, when it is a contact dermatitis, you know that it looks so difficult for the patient. I am not using the word ugly though. that they feel very unnerved when they are coming to a gathering, because you know that you have to use your hand. We people have got the tendency to use their hand not only for handshaking but to express themselves. So if they have a lot of this kind of rashes, they will have to hide their hands and just sit there quietly, kind of. So it is a lot of anxiety and depression also go along with this kind of rash. So how will you manage this case? I just said this bit because sometimes we just treat the condition. We don't treat the mental situation of the patient. When they have this kind of rash, how bad they are feeling, what they are feeling, you have to ask them that how you are coping with this rash and what is your job, and definitely something will come out from there. Now if their job is something, say like why I use this situation that housemaid or somebody working in your place, they have got the rash. Sometimes people are afraid of having that they might have a contagious condition, so I will not keep them, so they want to hide it and they make things worse. So you have to explain to them that it is not at all contagious, it is not at all an infectious condition, it's you who is suffering, and it is a treatable and curable condition. That is number one. Number two, the anxiety you are having from this, I understand, but believe me, if we treat that, you will get complete cure, and definitely you will come out of this anxiety. So you don't need to give an anti-anxiety pill for this. So if they coming from anxiety to you, you need to ask what is making you anxious. So when it comes to management just for this condition, definitely we ask them not to use the detergent, but a houseman, you are asking them not to use a detergent. Can you understand what implication it has? So you have to advise them to use some gloves or whatever so that they can protect their hand from the direct use of detergent. Sometimes they are maybe allergic to latex of the gloves. So that is a difficult situation. In Western world, they can get latex-free gloves, but in our country, to get this kind of thing for the housemate is not easy. So in that situation, I feel very sorry for them how to handle this situation. And so if it is possible, you have to say buy this, otherwise your condition will be so bad that you won't be able to work. You have to stop your work. So they usually understand, they use it. Now, normal this cetirizine or fexofenadine or this hydroxyzine hydrochloride, why I'm mentioning this atarax to you in this particular case again, that it is sometimes so disturbing or itchy that they can't really sleep at night. So in that situation, you can use it. But actual treatment is regular use of emollient, some moisturizing like Vaseline, or you can get good emollient cream in the medicated cream. Topical steroids you can use if the less than 20% of the body surface involved, what we see that clobetasol, I prefer clobetasol, triamcinolone you can always use. So, but if the more than 20% of the body surface is involved for some reason, then you have to use oral steroids. So this is the boundary where you have to use oral or where you have to use the topical steroid. And you can use steroids in the hand, but sometimes they might develop from some cosmetics or something, some rashes there on the face. So you cannot, or some say we use mascara and these eyeliners, they might develop some dermatitis from mascara also. So there you cannot use the steroid because it will cause skin thinning. There you can use this tacrolimus for these delicate areas, this nasal fold, the eyelids where the skin is very soft and delicate. So remember this, these are the drugs you can use, but along with it, you have to avoid using the irritant which is causing the problem. Otherwise, it will not get cured. Easy, easy. A 26-year-old gentleman present with this itchy rash and fever for the last 2 days. I think all of you can recognize this rash from, I'm just waiting for the answer.
Perhaps all of us have had this in our childhood.
That's good. If you have it, there's a chance of getting another one is less. Yeah, somebody has mentioned something there.
Chickenpox.
Yes, chickenpox or herpes zoster, what we call when we use the scientific term. But this is the name of the virus, though. But yes, it is chickenpox. Now, there is a confusion about the infectivity period of the chickenpox. You know, when we were small, I contracted chickenpox just after my board exam. And that time we had 3 months of holidays after board, the secondary education. And I spent 3 weeks on the bed because that time the notion is unless all the uh, crusts are fallen off, you are not non-infective. So I was just fit and whatever active, but my mom was not allowing me to go out of the bed. And there is a mosquito net like thing, so we have to be inside the mosquito net. So it's horrible. But the thing is, with what I tell my patients, that see, if you have chicken pox in 2-3 days time, your fever will be over. Normally it is not that bad, even you can go out, but the problem is this is a disease for showing your selflessness. If you are selfish, you can go out, you can infect others. You are not selfish, you have to stay back home till you are over the infection. Now, infectivity period, there is a lot of confusion with it, but it starts 2 days prior to the appearance of the rash. And that time, the people is more infectious when the day 1, day 2 kind. And then in some book, they said after a week of appearance of the rash, or some book says that it is when all the rashes have been crusted. So it is not falling off of the crust, but it is just crusted until that time. Now the mothers, they come and ask us very common question that when I can send my child to school. So after 10 days, they can go to school. After appearance of the rash, from there to 10 days, they can go to school, but it all depends on the rash. Now with the vaccination program in urban population, even if and also you will see the chicken pox. It's not that it is not happening, but the milder varieties are happening. But say in our generation, we didn't get the vaccination that time. So we are getting a lot of cases of adult chickenpox. And adult chickenpox can cause more complication than pediatric chickenpox. So that you have to remember, particularly with the pneumonia bit, lung infection. That is very serious condition. And the problem is chickenpox pneumonia, as it is a grave condition, you have to send the patient to the hospital, and the hospital refuses admission. So only if there is an infectious disease hospital in your vicinity, then only you can send the patient there. You cannot send the patient to a general hospital. So there is a limitation. So you have to treat the patient at home at your best. So when you are managing this case, ideally the treatment should be started within 72 hours of appearance of the rash, right? So we use aciclovir 800 milligram every 2-3 hours. Mine means 5 hours, 5 times a day for 5 days. So 25 tablets, 5 times a day. Now people say that vanciclovir and the other drugs, they are better because you can use 3 times. But again, the paper is saying it is more, acyclovir is more effective because vanciclovir and another famciclovir, these are precursor of the drug. So they have to change into this group acyclovir. That is why it is still, we have seen that it is more effective. And if you give this, that what will happen is that the chickenpox will finish up in 3 days? No, it will restrict the spread of the virus. So it will restrict the progression. That is why if you give it within 3 days, it makes sense. If it is more than 3 days, it does not make any sense to give it. Now, infectivity period I mentioned, and symptomatic treatment you can give, that antipruritic or the paracetamol tablet or some calamine lotion, even coconut water to take the stain off later on. So whatever you think is right, you can tell them. So all of us are experienced with the chickenpox.
Audrey, another question here.
Yeah,
There's a doctor who's asking about the use of acyclovir ointment.
right. Actually, the acyclovir ointment tube is this small and it's quite expensive. And chickenpox is quite widespread. So if you use the ointment, it won't make any difference. I mean, why am I using? But if it is a shingles, then you can use the ointment. But with this zoster chickenpox, if because it is all over the body, you will at least need 3-4 tubes every day to apply all over the body. And also the tablet, it helps to control the infection if you use it on time, but it hasn't got any advantage, the ointment. That is why it is not actually advised to use ointment in chickenpox.
Thanks, Audrey.
Interesting bit is coming now. His wife is 36 weeks pregnant. Now, the question is, risk of transmission is higher in early pregnancy or in late pregnancy? Here, please give an answer. Early or late? You have to write E or L. That's it. You just type E or L. Risk of transmission is higher in early pregnancy or in late pregnancy?
I personally am thinking early pregnancy, Audrey.
Anybody else has come up with E or L? Nothing.
Not yet.
Okay. So maybe you have something in your mind. You write it down. You just match with the answer. Does she need any precaution? Or if she develops rash, what are the risks to her or to the unborn baby? Right? So my answer is rate of transmission is higher later in pregnancy. The interesting bit is we always think any infection in pregnancy, it usually affects the fetus in early pregnancy because the organogenesis happens. Yes, it is true. Because if it infects the baby fetus in early pregnancy, fetal varicella syndrome happens, where there is limb deformity, scarring, there is CNS problem, there is mental retardation later on. So all these things happen. Also miscarriage happens if the mother get infection or contact less than 20 weeks. But if it happens later in the pregnancy to the mother, the chance of transmission through the placenta is more. So the placental barrier gets weaker in the later part of the pregnancy, and there it can cause severe intrauterine infection or even death of the fetus. And also just after birth, so if it happens 3 weeks before the delivery, the people can develop neonatal shingles at birth, and that can be quite serious. For mother, the risk is chickenpox pneumonia. And in this situation, I have to tell you that sometimes we have to find out that what we should give. If the exposure happens, say in this case, the husband has got the problem, wife is pregnant. So first thing, they got worried, what will happen to my baby? So if the mother has had the chickenpox, the risk is not there because she has already got the antibody. Sometimes they can't recall, but we have to check the immunity. So we have to check the antibody for the varicella zoster. In 80% of cases, the antibodies are there and the risk is minimal. But if there is at risk, you know that there is a risk, at-risk patients or diabetic or previous history of miscarriage or a high-risk pregnancy. In that cases, give a varicella zoster immunoglobulin if the contact happens within 10 days of exposure. So they come very early. If they come after 2 weeks, you can't do anything about this immunoglobulin. And if the patient is at high risk, then, or it happens in the later part, because as I have said, that later part, the risk is high, you have to give prophylactic acyclovir. But what we have seen that as acyclovir cannot cross the placenta that well, you have to give intravenous. Oral medication does not work that well, so you have to get involved the gynecologist there. Last case, I think the last case we finish with a simple one. Everybody can understand. It is not a scratch or not an accident or not Cullen sign or whatever sign we get after pancreatitis. It is the simple shingles, the red erythematous base, and there is some vesicles there, and it is just stops in the midline. It is unilateral. It can't be anything else. Many a time we miss this problem because patient says, I have got somebody with kurta or somebody with a shirt and a vest. They say, I have pain in this area, doctor. And we just say, okay, either it is musculoskeletal, could be renal, write an ultrasound. Unless you see the skin, you won't get the idea. And also, this infection sometimes fooled us because this rash might appear 3 days after the pain. So if they say come on the second day of the pain, because pain is so painful, and if you ask the patient, this pain is very different from the pain we get. So in this situation, when you come with the management, yes, we give acyclovir again if it is started within 72 hours. And the role of steroid is controversial, but to reduce the extent of post-herpetic neuralgia, if the rashes are just like that, what you have seen, you can use steroids in a dose of 30 milligram for 5 to 7 days. Amitriptyline for this burning pain, anticonvulsant like gabapentin, pregabalin, and also you mix and match of NSAID. So all these medicines are in hand because post-herpetic neuralgia is a really, really painful situation. That it can prolong up to 3 to 6 months even. When I've seen a patient complaining of pain even after a year with this after a herpetiform eruption. So you need to know what are the medicines you can use to give them some relief. So with this, I know I am overshooting the time and I'm finishing off with the part 1 of the skin problem. Next day, we might start with the second part.
Thank you so much, Adraja. That was really very interesting. And yes, I got to know a lot more than I usually use in my practice. So this is going to be very interesting to see what part 2 has in store for us. For the doctors who have joined us, thank you so much for your patience and listening to us and being interactive. We would really want to know from you what are the things that you would want us to talk about? What are the things that you would want to learn from Dr. Adraja's rich experience? And you can write to us at hello@medibuddy.in, and we would be very happy to see if we can add on more information to the list of CMEs we have lined up for you. Thanks, Dr. Adraja. Really kind of you for your time and patience and so much of information in just 1 hour. Thanks a ton.
Thank you so much. And thank you all for participating. I would love to hear more from you in next session. So that the interaction enriches me also. Thank you. Thank you very much.
Thank you, doctors. Have a good night.